Hey guys, welcome back and welcome to Respiratory Embryology. Let's get started. The development of the respiratory system occurs in 5 periods. Let's take a look at the image in your first aid text to help us along with this process. The very initial phase is called the embryonic phase and surrounds the development of the lung bud from the distal end of the respiratory diverticulum during week 4. The lung bud eventually divides into 2 bronchial buds that will branch off and form the 2 main stem bronchi, giving rise to both secondary and finally tertiary bronchi. Here we can also see the pathologic development of a tracheoesophageal fistula. The next stage is the pseudoglandular stage. This stage occurs from week 5 through week 16 of development. Here, the terminal bronchioles are formed from the endodermal tubules. We also see the beginnings of the pulmonary capillary network. At this stage, respiration is still impossible and thus the fetus would be non-viable at this point. The canalicular phase begins at week 16 and ends at week 26. Here, the terminal bronchioles will eventually give rise to the respiratory bronchioles and alveolar ducts. There is also a prominent capillary network now present. The most important time to point out is that respiration becomes possible during this stage, specifically during week 25. The saccular phase will occur from weeks 26 to birth, when the alveolar ducts are developing into the terminal sacs. This is also when the pneumocytes of the lung will develop. And finally, we have the alveolar phase, occurring from weeks 32 to about 8 years of age. Here, the terminal sacs will develop into adult alveoli. In utero breathing also occurs during this stage via aspiration and expulsion of amniotic fluid. At birth, this fluid will get replaced with air and the pulmonary vascular resistance will rapidly decrease, allowing the newborn to breathe in oxygen independently. Let's talk about some congenital abnormalities that might occur during lung development. First, we have pulmonary hypoplasia. This is an abnormality that is characterized by a poorly developed bronchial tree, usually occurring in the right lung. This condition is associated with congenital diaphragmatic hernia and bilateral renal agenesis. Now quickly, what pathologic sequence can you think of that might result from bilateral renal agenesis? Correct, Potter sequence. When we use the term sequence here, we're actually referring to a chain of events that leads to a certain physical pathology. For example, in Potter's sequence, the final pathologic manifestation this disease is known for is pulmonary hypoplasia, secondary to oligohydramnios, or the instance of too little amniotic fluid in the uterus. The small amount of amniotic fluid leads to compression of the fetus and the developing lungs. The fetus simply runs out of room to develop properly. The sequence of events that can lead up to oligohydramnios and pulmonary hypoplasia are those that are associated with decreased production of amniotic fluid, i.e. bilateral renal agenesis, and obstructive uropathy in utero, multicystic kidney disease, or renal hypoplasia, to name a few. Another commonly tested sequence is the Pierre-Robin sequence. Do you remember the triad of this pathologic condition? Correct. Retrognathia, glossoptosis, and cleft palate. All of this occurs because of a mandibular hypoplasia defect, the actual trigger to the sequence. The next congenital abnormality we need to discuss is bronchogenic cysts. These are caused by abnormal budding of the foregut and dilation of the large bronchi. These often drain poorly and are a nidus for chronic infections. Any idea what other pulmonary pathology also causes dilation of the large airways? Well done, bronchiectasis. This is an image of bronchiectasis in the lung. We'll talk a bit more about this in the pulmonary pathology section, but notice the round, dilated airways seen in the lung peripherally. Bronchiectasis is also commonly seen in cystic fibrosis patients that have chronic infections in their lungs. Although bronchogenic cysts are congenital and bronchiectasis is a pathology process secondary to lung injury, they both create these cystic dilations in the lung tissue that are very prone to chronic infections. Flash quiz. During which phase of lung development does respiration become possible? The canalicular phase, which lasts from week 16 to week 26. Pneumocytes are high yield for the boards as they play a crucial role in both gas exchange and respiratory physiology. First, let's talk about type 1 pneumocytes. Type 1 pneumocytes make up most of the alveolar surface. Now, what's their cellular morphology? These cells are squamous cells. They're thin and flat, which make them great for gas exchange at the alveolar capillary interface. Type 2 pneumocytes are less abundant but are extremely important. This slide has been stained for surfactant, so the type 2 pneumocytes are actually showing up brown on histology to make them more easily identifiable. Type 2 pneumocytes secrete pulmonary surfactant from lamellar bodies. It's the pulmonary surfactant that decreases the alveolar surface tension. Here's a little mnemonic for you. Type 2 goes with lamellar, and the 2 kind of looks like the double L in lamellar. Interestingly, these cells can differentiate into either type 1 or type 2 cells and are the ones that proliferate during lung damage. For example, in acute respiratory distress syndrome, also called ARDS, there is diffuse alveolar damage. The type 1 pneumocytes are the ones that are mainly affected simply due to their abundance in the tissue. Once damaged, the alveolar membranes become permeable and a protein-rich fluid leaks into the alveoli, eventually forming the classic hyaline membrane seen in this condition. However, it's the type 2 pneumocytes that will begin to proliferate in an effort to regenerate both type 1 and type 2 cell populations. This concept of tissue regeneration after a pulmonary insult is commonly tested on the board exams. What other cells are important for you to know?
How about Clara cells, otherwise known as club cells, as we see in your textbook?
These are non-ciliated columnar cells with secretory properties. Where are they found? They're found in the bronchioles, not the alveoli. They protect the bronchial epithelium by secreting a surfactant-like solution and degrading toxins via what pathway? Very good, the cytochrome P450 pathway. Let's focus on the Clara cells column only. We see that the Clara cells are present only in the bronchioles and terminal bronchioles, but not in the alveoli. Think C for Clara and C for conducting zone, the area that these cells remain in. Okay, now let's get back to surfactant. So I said a little earlier that surfactant is secreted by type 2 pneumocytes. Now what is the main component of surfactant? Well, it's mostly made up of a phospholipid called dipalmitoylphosphatidylcholine, which allows surfactant to decrease surface tension in alveoli. According to the law of Laplace, the collapsing pressure equals 2 times the surface tension over the radius. I think it's also helpful to sketch out the relationship for yourself. Looking at this equation, we see that the variable P, or collapsing pressure, will have a linear relationship with whatever change occurs in the numerator, which is in this case surface tension. As surface tension increases across the alveolar epithelium, the alveolar collapsing pressure will increase as well, and vice versa. In contrast, the variable P will have an inverse relationship with the changes occurring in the denominator. As the alveolar radius decreases, say during exhalation when air moves out of the alveolus, the collapsing pressure will rise, predisposing that alveolus to collapse. So, what's the bottom line? With surfactant decreasing surface tension, you should see an increased lung compliance and a decreased work of breathing because more alveoli remain open at the end of the breath. And if they do collapse, it requires less gas pressure to reinflate them. Finally, surfactant synthesis is a major part of fetal lung maturity. Later, we'll talk about neonatal respiratory distress syndrome, which is where you don't have enough surfactant at birth for efficient respiration. Any idea how you'd treat this? Good. Maternal steroids prior to birth. The glucocorticoids help to expedite fetal lung maturation and are most effective if administered to the mother once it's known that the child will be born premature. Now, as we discussed earlier, there are type 2 pneumocytes that secrete surfactant. This decreases alveolar surface tension and increases lung compliance and therefore decreases the work of breathing. The importance of surfactant is highlighted in neonatal respiratory distress syndrome, seen in this X-ray, where the pathology is related to the neonate's lack of surfactant. The deficiency in surfactant due to the immaturity of the neonate's lungs leads to an increase in surface tension, decreased compliance, increased work of breathing, and alveolar collapse. On the chest X-ray, you can see the diffuse interstitial infiltrates. So who is at risk of NRDS? Well, classically, it's preterm infants, especially those before week 35. Other risk factors include maternal diabetes and C-section. An important marker of lung maturity is the lecithin to sphingomyelin ratio. You can find this ratio in the amniotic fluid. Both lecithin and sphingomyelin are lipids in surfactant, but it's mostly lecithin that gives surfactant its properties. Can you recall the most important lecithin molecule we're concerned about here? Very good, dipalmitoyl phosphatidylcholine. In NRDS, the L to S ratio is generally less than 1.5, whereas a ratio of 2 or greater indicates a low risk of NRDS. Survival is poor in neonates younger than 24 weeks. Interventions to improve survival include administration of maternal steroids before birth to accelerate lung maturation. You can also give intraalveolar administration of artificial surfactant after birth. Finally, you can also give a CPAP or intubation with oxygen. However, too much oxygen in the perinatal period can lead to complications such as retinopathy and bronchopulmonary dysplasia. Now, will an intubated baby develop retinopathy? Usually no. It's more associated with oxygen tense, causing initial cessation of blood vessel formation because the oxygen tension in the retina is appropriate. Once the oxygen is removed, the relative hypoxia in the eye causes blood vessel overgrowth, which can result in blindness. If the baby has persistently low oxygen tension in the blood, what cardiac complication are they at risk of? Good, a patent ductus arteriosus. Alright, let's finish this section off with a board-style question. The X-ray shown in the image is from a child with a congenital condition. Which of the following is the most common cause of death in infants with this condition? The answer is E, pulmonary hypoplasia. Pulmonary hypoplasia is the most common cause of death in infants born with a congenital diaphragmatic hernia. When the pleuroperitoneal folds fail to fuse with the other compartments of the diaphragm, a hole is created that allows the bowel into the thorax, seen here. The physical compression of the bowels on the lung buds then prevents full development of the respiratory system. This compression leads to a common presentation of dyspnea and cyanosis, and unless it can be repaired surgically, eventually it can lead to death. Alright guys, that's it for respiratory embryology. I'll see you next time.